Welcome to Mayo Clinic's ECG segment, Making Waves, continuing medical education podcast. Join us for a lively discussion on the latest and greatest in the field of electrocardiography. We'll discuss some of the exciting and innovative work happening at Mayo Clinic and beyond with the most brilliant minds in the space and provide valuable insights that can be directly applied to your practice. Welcome to Mayo Clinic's ECG segment, Making Waves. In this episode, we explore an exciting evolution in cardiac pacing, conduction system pacing. Traditionally, cardiac pacing has relied on stimulating the right ventricular apex or free wall, but conduction system pacing aims to restore a more physiologic form of pacing by directly engaging the heart's native conduction system. And this approach has the potential to reduce pacing-induced cardiomyopathy, as well as optimize a lot of the long-term outcomes in selected right patients. And now joining us today to look at the fundamentals, the rationale, and the clinical implications of conduction system pacing is someone that you guys probably know, Dr. Nicholas Tan. Dr. Tan is a cardiac electrophysiologist at Mayo Clinic in Rochester, Minnesota, and he's joined us before. He began his training in biomedical engineering at Johns Hopkins University, and then he earned his medical degree and master's in biomedical investigation from the Cleveland Clinic Lerner College of Medicine. He completed his residency and fellowships in internal medicine, cardiology, as well as cardiac electrophysiology here at Mayo Clinic. And more recently, he completed his master's in medical device innovation at the University of Minnesota. His clinical and research interests include device-based therapies and catheter ablation, with a focus on improving patient care through technology-driven innovation. And I also want to mention he's done a lot of his role also in cardio-oncology, especially as it relates to arrhythmias. He's put a couple of those episodes together, so I'd go back and listen to those. But Dr. Tan, thanks so much for joining us again.
Thank you for having me.
So conduction system pacing, certainly something we think about, we see a lot almost in a lot of our practice. And I wonder if you can kind of share, highlight what is the difference between now this conduction system pacing and more of the conventional, traditional ways of how pacing was traditionally done.
Yeah, so I think to take a step back in terms of what the cardiac conduction system is, your own internal pulses start from the sinus node, so that's your internal pacemaker, and the impulses make its way down to the AV node, the atrioventricular node, and down to the His bundle, and eventually to the right and left ventricle via the right and left bundle branches, respectively. So there is a very synchronized, coordinated flow of electricity, which then mediates the muscular contraction of the atria and ventricles. So historically, whenever we try to pace the heart, the reason that we do it is because there is a slow heart rate, and that needs to be compensated for externally. And so that would involve placement of these pacemaker leads, usually in the right atrium and in the right ventricle. And so they act as external stimulators to basically make up for any defects in the conduction system, anywhere from the sinus node all the way down to the bundle branches. So whenever we used to position these leads, we usually try to put them in anatomically convenient locations, if you will. So for the right atrium, we put the leads in the right atrial appendage, and for the ventricular lead, we usually position it near the apex. So it's a very convenient, very reproducible means of pacing the heart. The problem is that that's not where the electrical impulses typically arise from. And over time, if you're constantly stimulating the heart from these non-physiologic locations, you can end up with muscular defects. And by that, I mean cardiomyopathies that are actually related to the dysynchrony that's caused from the non-physiologic electrical pacing. So conduction system pacing basically means that you're using the existing conduction system, you're co-opting it and using part of it at least to try and provide better synchrony, both in the atrium and the ventricle. Most of the work that we have right now, most of the research has been in ventricular pacing, but there's some research in terms of atrial synchrony as well.
Very nice. It's really helpful. As you mentioned, pacing outside of the conduction system, the slower activation and the risk of cardiomyopathy, if you can actually hijack or jump back on that highway track of the normal intrinsic conduction, maybe you can kind of have that more synchronous conduction. And so when you think of that, how do you actually perform that in the lab?
So in order to try and use the conduction system, you have to be able to find it. And so the difference between how we used to do it with standard ventricular apical pacing is that in addition to using fluoroscopic markers, anatomic markers, you have to use electrical signals as well. And this involves some degree of electrical mapping of signals and where you ultimately implant your leads. Now, this is still an evolving field, but the general principle is you want to bring your ventricular lead towards the ventricular septum. So that can be used, that can be done using fluoroscopic guidance for the most part. But then the other aspect to it is to monitor electrical parameters as you go deeper and deeper into the septum, which is where the conduction fibers are living. How far can you go, and how much should you go before you start engaging the conduction fibers? And that involves pacing the heart at different outputs and seeing if you are starting to capture the conduction fibers as you start to penetrate the ventricular septum. And if you're not really getting to where you're going, you have to move to a different location. So it involves using different tools that we hadn't used before, being more cognizant of where the conduction system is relative to the fluoroscopic markers that we have relied on in the past.
I see. And so the fluoroscopy helps almost approximate, and then you're trying to really hone in on, are you getting and tapping into that conduction system with some of the maneuvers as you screw into the septum. But, when you think about this, what patients or what situations would you say, hey, the traditional means is the way to go, but no, maybe not. We should do conduction system pacing. What's your thoughts or rationale for choosing this approach?
To be honest, nowadays I usually think about which situations I would use apical pacing as an exception. So conduction system pacing, for the most part, for myself, has been the default option for ventricular pacing um, outside of very select situations. So unless the patient requires an ICD, that's at least for now, that would involve positioning the ventricular lead in a standard location, in a non-conduction system pacing location. But in most other situations, I would consider it because the risk of RV pacing cardiomyopathy is real. There's maybe a 10 to 15% chance of this occurring in all comers, even if they have a preserved ejection fraction to start with. And then also in terms of safety, because by definition, whenever you're positioning the CSP lead, you're positioning it along the septum, and the septum is not a location where you can get tamponade or perforation. So from a safety standpoint, I think it also makes a lot of sense for us to be using CSP as default.
I see. So it's more of, the exception of when should I go the other way in putting more of a traditional lead. I guess you kind of mentioned the septum and potentially a safer approach. What are some of those risks or uncertainties that, you have with conduction system pacing or, even and have you seen benefit with it?
So I think in terms of acute procedural risk, if you're not perforating into the epicardial space, if you're not putting a lead outside of the heart, Um, even with CSP, if you're going too far, you're going through from the right side of the septum towards the left side of the septum. So if you do perforate, you're going to be perforating from an endocardial perspective. So you're creating a small defect between the right ventricle and the left ventricle. Now, the acute risk for that is relatively small, especially if you recognize it. However, if you don't and you leave the lead in place and it's sitting in the left ventricle, that can be potentially a nidus for clots to form and therefore increasing the risk for stroke, especially if the patient's not on anticoagulation. Now, if it completely perforates into the left ventricle too and is free floating, that's also where you can lose capture and lose pacemaker function. So that's another risk that people have to be mindful of with this technique. In terms of the long term, one of the biggest questions that we have regarding the safety of these leads or the positioning of these leads is what happens if we need to take them out. So when there is an indication for extraction, say the lead is malfunctioning or the device is infected and you have to take the lead out, how easy is it going to be? Are there any issues that we may encounter? Those are things that we don't know yet just because CSP is so much newer. And this is something that we may find out in maybe 5 to 10 years from now regarding the long-term outcomes and risks associated with extraction. But that's one of the biggest questions that we have right now that we don't have firm answers on.
Yeah, you can certainly see those, especially like you said, newer, but if they're older leads, 10, 15 years and have to be replaced. But this is really exciting. And, it's good to see that we're kind of moving the needle, and can we, hijack the normal conduction system and preserve the ventricular synchrony. Well, in today's episode, we explore the fundamentals of conduction system pacing and how it represents a more physiologic alternative to the traditional right ventricular pacing that we've done and still will do. But as Dr. Tan said, maybe that's more of the exception to more of the default of using this conduction system pacing. Dr. Tan helped us understand how conduction system pacing works, really hijacking that conduction system, getting and trying to preserve the native conduction, when it should be considered, and then the opportunities and limitations and still the unknowns with this evolving technique. Dr. Tan, thank you for sharing your expertise, joining us, teaching me and many of us. We appreciate your time and insights and hope you'll join us again in the future.
Thanks a lot. Happy to be here. Thank you.
Thank you for joining us today. We invite you to share your thoughts and suggestions about the podcast at cveducation.mayo.edu. Be sure to subscribe to a Mayo Clinic Cardiovascular CME podcast on your favorite platform, and tune in every other week to explore today's most pressing electrocardiography topics with your colleagues at Mayo Clinic.
This has been a Mayo Clinic podcast.
At Mayo Clinic, continuous learning fuels world-class care. I am Dr. Francisco Lopez Jimenez, Chair of the Division of Preventive Cardiology. If today's episode gave you a fresh insight, imagine what a full course can do for your patients. Please check out the link cveducation.mayo.edu and explore our live and online programs, quick on-demand modules, and CME accredited masterclasses created and taught by the very voices you trust here. Join thousands of clinicians who have already turned curiosity into expertise. Level up your practice now at cveducation.mayo.edu.